managing cancer patient is capital intensive.
Yes.
No amount of money, a single cancer patient, through the course of his treatment can engulf up to 30, 40, 50 million. So it's actually not a joke. This 50 million, if you put it for malaria, upper respiratory tract infection, and some minor ailments, it can actually go a very long way. It can support or treat millions of people. So you see, and what the National Health Insurance Agency is getting is actually very minimal. So pushing it completely, a blame on the National Health Insurance Scheme, I still think it's...
So there has to be... There has to be not somewhat, in fact, there has to be an expanded plan in place.
There has to be, yes.
Multi-sectorial.
Yes, and I believe they are currently working on that, on how to expand. We had a series of meetings, when it comes to this issue of Cancer Health Fund. When it was first transferred to NICRAD, we formed a committee, the NICRAD and the National Health Insurance Scheme, to devise model on how best we can improve funding of this special group of patients that we can have, and how to disburse the fund. I think we were able to come up with 3 good models, of which we selected one. But sometimes implementation of virtually whatever you draft up, the policies, takes time because of the lack of funds. So we are trying to see an increased funding into this Cancer Health Fund, and then we can continue from the discussion where we stop and see how we can improve the funding of this special group of patients.
Prof, of course, already you've alluded to the progress or status of the National Strategic Cancer Control Plan, but I'd like to know, does the current plan, the subsisting plan, does it spring from the previous plan, a similar plan that was launched, I think that was in 2015, with some certain amounts pegged, to it. I think it was a total of $250 million to be actively used for interventions during, I think it was between 2018 and 2022. Your own plan, the subsisting plan, did take off in 2023, I think, if I'm not mistaken, and it's supposed to last to 2027. That's the national. How do they correlate? And, how do they correlate essentially, and where are we right now?
Okay, so you've actually rightly captured it. What we had before was 2018 to 2022, the National Cancer Plan. We actually drafted that plan to give a guide to how the country faces cancer menace generally. So a cut across the areas of cancer prevention, cancer research, treatment, and in general control. We have made some certain positive moves there. I cannot recall exactly the percentage of the coverage, the success that we have recorded in the previous plan. But the new plan is just like a continuation of the previous plan. We normally change it, every 5 years to assess where we have actually improved, make a positive, mark, and then where we need to go back and then change the strategy, just like other countries are doing in the world. So the current National Cancer Plan that we have included so many new things that were not hitherto present in the previous plan, like the issue of survivorship, the care for those that are cured, or those that have been treated and they are now going about doing their normal lives. They too, they need care, which was heavily neglected, and some part of also palliative care. They are all part of the current National Cancer Control Plan. But most of the activities that we are doing, starting from the year 2024, we are following the the National Cancer Control Plan. The current one is like our roadmap. It's the one that is giving us a guide to what we do and what we are currently doing and what we will continue to do till the year 2025.
Prof, finally, in rounding off our conversation, but let me just quickly say this before I land with a question. I would like to reiterate here and now that, one of the things that patients, and we've talked about this, you yourself, in fact, you even started this whole capital-intensive nature of treatment. So I would just like to reiterate that one of the things patients and, cancer-impacted families often realize, and they do realize it quickly, is that the cost of treatment, whether in government-owned hospital, is very similar to that of private facilities here in Nigeria. So it is expensive here, it is expensive there, generally. But in terms of the plan, having a roadmap already, some of the things that are not previously captured, now being captured, what other innovative solutions are we looking at designing nationally? Perhaps as a policy, perhaps as a practice, to engender, some time ago you talked about 6 new machines being acquired, 6 tertiary institutions being expanded to, just so we can also increase access. I guess these are some of the plans.
Access, yeah.
So how do we engender a robust ecosystem? That system, that pushes for progress in cancer treatment and management here in Nigeria. Finally, Prof.
Okay. So just like we have mentioned, those were just part of activities that the Institute is currently doing to improve access to cancer care services in the country. Access, we also improve access through this cancer health fund that we are currently pushing because we are still treating. There is also a program we call Cancer Access Program, the National Cancer Access Program. Now, through that program, what we did is that the federal government entered into a collaboration between us and the pharmaceutical companies that we have there, about 8 or 9, to supply us with good quality cancer medications to our patient at a subsidized rate. Subsidized rate here, I mean at 50% of shelf cost. And it's currently ongoing, and we are getting these services. They have agreed to supply us, and we are currently using that to assist our cancer patients. This is all with the hope to improving access to quality care in all the tertiary hospitals that we have in the country. I've earlier mentioned about the screening services that before the coming of this government was not in existence in our tertiary institution or in anywhere. Sometimes if there is no hospital that you can just walk in and say you want to get screened, and you can be pointed to a department or a unit where you can go for that screening. Now, as I'm talking to you now, our machines are on ground for screening a lot of cancers that we have commonly, these 5 most common cancers. This is happening for the first time in the country. We are also into a lot of collaborations with international organizations, international hospitals and communities on how to support cancer treatment generally. We have St. Jude Hospital, who we are currently working and collaborating with to assist with, the children that have cancers in the country, to assist them immensely in the provision of a kind of special cancer access program for children. We are working with International Agency for Research Control, that is IRAC, and African Cancer Research Network, to standardize the nature of cancer data that we have in the country. We are working with Mayo Clinic, Milken Institute, conducting, we also have Syndicate Bio, where we are currently conducting a synergistic research in the field of cancer. With the Syndicate Bio, is actually the project that we are conducting is what we call it a national genomic study. It is the first of its kind in the country, And the essence of that research that we are currently conducting nationwide is to know the signature of virtually all the common cancers that we have, and then have a database where where the modifiers, the movers and shakers of cancers, of these 5 common cancers, are the genetic mutation, just like I mentioned, the signatures, can be known. And once known, that will give a room for the design of novel therapies that are purely based on our race. Because, you know, I've always mentioned that sometimes most of this, the new innovative drugs that we are getting are purely based on the research conducted on Caucasians. Some, and then they just transfer those drugs to us, and then with the expectation that some will work. Yes, definitely some will work, but some will produce more side effect to us than cure, because the study or the research or the clinical trial was conducted purely on the white. So if by the time we finish these studies, we have our own signature, so we know the genetic map of the modifiers of these cancers that we have, the signature of virtually each and every cancer in black race. It is not going to only benefit Nigeria, but African population in general.
Indeed. Yeah. It's quite significant, I must say, in terms of research, in terms of treatment. Director General, National Institute for Cancer Research and Treatment, Professor Osman Ali, I'd like to thank you so much for coming on Insight. It's been great listening to your insights on this issue. We'd like to see you do some more work so that we can give, you know, some ray of hope to cancer patients and impacted families in Nigeria. Thank you so much for coming on our program.
Thank you very much for having me.
Any issue of public concern,
our job is to help you gain clarity and make sense of it all.
This is not really healthy for our democracy.
There's a lot of aggrievance in terms of who has been in power longest and who becomes the governor of the state.
It's also in the quality of food being consumed.
After all, perception is insight.
and gaining understanding is also getting insight.
And that's Insight today. Thank you so much for your time. Don't forget, we are one. Let's remain tolerant, loving and kind to each other. Life is a gift from God. It is beautiful. Be your brother's keeper. Shun acts capable of dividing us. We'll see you next week. Bye for now.